Hello and welcome to the 21st CROI in Boston. It's the Conference on Retroviruses and Opportunistic Infections. My name is Jeff Taylor, and today we're doing a panel discussion on metabolic complications of HIV. And we have a wonderful panel assembled today. I'll quickly introduce them and then let them delve into the issues. On my left, we have Dr. Pablo Tebas from University of Pennsylvania, Charles Flexner from Johns Hopkins, Priscilla Hsu from UCSF, UC San Francisco, and Dr. David Wolf from University of North Carolina. So welcome and thank you for joining us today.
Thanks.
Thank you.
Thanks.
So we're finally 21, so that's why they gave us wine?
Really a good idea.
Well, speaking of wine, cardiovascular issues were a hot topic this year, so there was a lot happening. And for our distinguished panelists, what do you think were some of the important issues?
So I think there was a session on heart failure and cardiovascular disease, and I think this is kind of a change. I think as the spectrum of HIV has aged and changed somewhat, the spectrum of cardiovascular diseases has evolved as well. So there were lots of interesting studies on different biomarkers and predicting mortality, biomarkers predicting structural heart disease, so namely diastolic dysfunction.
Right, and I think one thing that we saw, whether, we can always talk about confounding, and I think that was a topic that was brought up a lot this session. But I do think that there is more bad things happening to people with HIV, whether it's the virus, whether it's the drugs, whether it's hard living. But I do think all these studies are showing that disproportionately there are more things like fat in your myocardium, and maybe Priscilla can tell us why that's bad for you. It was sort of an eye-opener to me. But even heart failure in people living with HIV, for whatever reason, is just more common.
Yeah, I think there was a big emphasis on heart failure, but actually more on what we call diastolic dysfunction. Right. So not reduced pumping function of the heart, but more of an inability of the heart to relax upon filling, so a stiffness of the heart. And in patients without HIV, that is strongly associated with increased mortality. Right. What's interesting in HIV, we don't know, is it the results of the HIV infection itself? Is it the medication? Is it hypertension, which would be some of the things that would cause this in an uninfected population? So I think this is something that will be very interesting to study in the future.
Yeah, a lot of the studies that were looking at markers were pretty small, so it was really hard to make sense of it.
Sure.
I really like that others like you have tried to look at more of the correlation between generalized inflammation and end organ disease, and looking at acute coronary events and acute heart events and how that might be related to some of the problems that people live with, whether it be due to immune activation or other things. And I think your study looking at the spleen and also the bone marrow of people living with HIV is showing things are lighting up. I mean, people do have some degree of inflammation. So one question I have for you is, when you look at those pictures and you see bright colors, you think, wow, that's a lot. Is this a lot of inflammation, or is this just a little bit more than other people? Can you put that a little bit in perspective for me? As I look at those pictures, they look glaring, but I don't know what the, relative to a person who doesn't have inflammation, how much inflammation is that?
Right. So, I think that's a very important point. And what was interesting is, these were small studies, so off the bat, this is just, looking at 27 or so HIV patients. And even despite that small size, being able to show significantly increased levels of inflammation in the bone marrow and the spleen, which I don't think has been described in HIV yet. Right. And it's interesting because those similar levels were the levels that we found in HIV are similar to some of the studies in patients without HIV who had acute coronary syndromes or even chronic stable angina. So there's a study that was literally just published like weeks ago in patients who don't have HIV infection that quantified metabolic activity in the spleen and the bone marrow, showing that patients' controls were the lowest, patients who had just chest pain, so chronic angina, were next highest, and then patients who had like an acute coronary event were at the top of the spectrum. Wow. So even that gradation has been shown in other populations that are pretty small too, small studies. So.
I mean, in small studies, it's always risky to extrapolate, and the problem is always people tend to focus on the HIV patients, but I think the focus should be in the controls. Yeah. Who are the controls? Do they have the same frequency of co-infections like hepatitis C, C and B? They have the same type of habits? When you look at cross-sectionals of the population, HIV patients tend to have more risk factors for many of the things that we see, and we sometimes think are complications of HIV or the treatment of HIV. and they smoke more, they take drugs more, they use other drugs, and that can be confounding. I think it's clear that there is a signal there for HIV by itself, even when you control. But when you interpret it in small studies, you have to be very careful about the control group.
So you think that you do a better job of comparing apples to apples?
But it's so hard to find the apple.
The problem
it's
is
impossible.
patients that are very with HIV are very unique, and I mean, the best control for somebody that's hepatitis C positive or has used cocaine is somebody that is hepatitis C positive and used cocaine. Usually they have HIV too. So it's very difficult to separate all the environment from
That's
so
why the
control.
Alive cohort from Baltimore, and maybe you can comment upon this, is very helpful because here's a cohort of people who are HIV positive and a separate cohort within this of HIV negative. They're all injection drug users or former injection drug users. And it was really interesting that in the control group, when they looked at IL-6 and D-dimer and an index looking at a formula, it was pretty high in the controls and associated with bad outcomes. And these are people without HIV.
So yeah, I think when you look at cross-section in particular, you have to be very careful with controls.
Interpretation of these studies is always hazardous for exactly that reason. Who are the control groups? Regardless, though, we are accumulating all of this evidence about increased risk for cardiovascular disease and cardiovascular events in people who are HIV infected, despite being fully suppressed by antiretroviral therapy. And we, as care providers, need to focus on risk factor management. We need to get our patients to stop smoking. We need to provide cholesterol control where appropriate. We need to consider statins where appropriate. I mean, there's a whole line, there's a whole cascade of things we as providers need to think about that we didn't perhaps think about so much 8 or 10 years ago.
Right, because this is what I tell my patients. You do have an increased risk of bad things happening to you. It may be, because I believe it's not so much an inflammatory storm in every single patient, and I don't think it's necessarily that every single person has a high IL-6 or whatever, or carotid. It could be because of your smoking, it could be because of your hypertension, it could be because of your cocaine, it could be because of your family history. But regardless, you do have an increased risk, and we have to try to negate that risk as much as pull the levers we can. There's only a few. There were some studies about diet and exercise, especially exercise here, some smaller studies, but it looked like inflammatory markers would go down, would improve when people did things like brisk walking or strenuous exercise. I know we're preaching to the converted that exercise is a good thing, it's easy to say, it's easy for us to say. It does seem to really work for people even with HIV infection.
And we talk about elevated inflammatory markers in people who are chronically infected with HIV despite being fully suppressed on antiretroviral therapy. These data also are true in people who are not HIV infected. If you have cardiovascular risk factors and inflammatory markers are elevated and you go on a regimen of regular exercise and you lose weight, your markers drop.
That's right.
So this is these are positive things that we can get our patients to start doing for themselves that don't involve taking more drugs.
That's right.
Yeah. Because that's the other thing that I think has been a thing here. When you try to evaluate systematically interventions to tackle inflammation, is negative study after negative study. I mean, we have the sevelamer to look at LPS as a pathogenic mechanism for the ongoing inflammation.
Rifaximin,
mesalamine. I mean, it was like a whole series of negative studies. I think the only one that has shown some signals is something that is used in statins, rosuvastatin. I mean, the Grace McConsey study with rosuvastatin shows some signals of decreased inflammation and
some markers. But
some
not,
markers.
it was in like a lot of the monocyte markers. It was not so much in the CRP and the other markers. So.
Right. She presented that last year, and then this year she did a really nice update where she's looked at additional data, including bone changes, and saw that there was a significant increase in bone density in the hip, which is a very good measure to look at. The spine wasn't there, and that's much more variable, but the hip increased dramatically compared to placebo, but there was a cost, and that glucose
Insulin
intolerance.
intolerance.
Yeah, so that was a problem. So there was more problems with sugar control. It wasn't diabetes, but it was more pre-diabetes.
But that has been shown in the population.
It's shown in HIV negative population before.
That there is an increased risk of insulin
You have to deal with
resistance.
this all the time. Do you have to
Yeah.
discuss with patients the risk of diabetes or glucose intolerance when you're starting on a statin?
I mean, I think, just to bring it back to a lot of points that Grace said, so in the patients without HIV infection, like the Jupiter study, there is an increased risk, but it's among those patients who are at extremely high risk for developing diabetes in the first place. And even among those patients, statin use has been shown to significantly reduce MI, cardiovascular events. So that's also the same group that benefits the most from statins.
Right.
So it's, clearly, a fine line to draw.
What is your take? You're a cardiologist. What is your take in the new cholesterol guidelines, and how is it going to affect the
It's
HIV?
very controversial.
Oh, yeah, I know.
Cardiology. So, as you know, it's not now focused on the LDL number, but it's
Yes,
looking
yes.
at a new risk calculator, which is not Framingham, it's adapted, and then looking at the potency of the statin, right? If it's like a moderate potency statin, like rosuvastatin, atorvastatin, or a low potency statin. So, I think we as cardiologists are still grappling like what it means for patients without HIV disease. I think now when I put on my HIV hat, what does this mean for our patients with HIV disease? Are those risk calculators accurate in our HIV population? Because it doesn't take into account things like inflammation, ART, things that maybe play more of a key role in our HIV patients. So I have a lot of questions. And
But
even
if
under
anything, the reading should be that more people should be on statins than currently are.
Well,
in
it
the general
depends.
population
It
and in the
depends.
HIV.
Because
Depends upon who
it
you're
depends
talking.
on the guidelines. So, like some patients, even with by the new guidelines, even if you have an LDL of 160,
You might not.
qualify for statin.
Because you're younger,
Right.
right? Yeah.
So you don't have diabetes, you don't have cardiovascular disease. So it's very.
Whereas
so
normally
that's-
you would have put them on before.
Like
They have
slam
170 milligrams per deciliter LDL. You'd say you've got to be treated now.
Yeah, but in
It's saying
general, you
don't, your
focus
risk is
more
low.
on if you have some risk, which our patients have
Right.
very frequently.
Right.
You're going to use a high dose of a potent statin and in a significant greater proportion than we are currently using. And the focus on cholesterol rather than in triglycerides, which has been a big discussion in HIV patients, is people basically, the guidelines.
They don't really touch on triglycerides at
No,
all.
yeah.
Right. So I think there's going to be a lot. I think there's it's like a 400-page document. There's like one sentence on HIV patients and protease inhibitors about potential drug-drug interactions, but it's clearly the HIV. There's a lot of specific issues that it didn't address at all.
So is it fair to say that after this conference, we still feel there's no sort of magic bullet, there's no treatment for your inflammation? We can talk about just decreasing your viral load decreases your inflammation. So HIV therapy overall is a good thing. That's number one. Perhaps better living, cleaner living, not smoking, not drinking, not doing drugs, and exercise probably also reduces inflammation to some degree in people who have inflammation. But I didn't really see anything else where you'd want to take something to reduce your inflammation. Did you all see anything?
I think there's a balance. Not all inflammation is bad. The goal is not to reduce inflammation to zero.
Right.
Because these inflammatory reactions exist for a reason.
Right.
They're protecting us from our microbiome
Right.
and from the world around us. And so what the challenge we face is to strike that balance between bringing down inflammatory reactions to things like chronic viral infections that are detrimental to our health, but not expose the patient to risk factors from the drugs we use or the interventions we use to bring those inflammatory biomarkers down, and to make sure that the goal is to improve long-term health and reduce things like cardiovascular risk, not to further reduce the ability of that person's immune system to respond appropriately when necessary to inflammatory stimuli.
Yeah, I think it's the excess inflammation that we're talking about. And just to be clear, sometimes when we do studies, we look for people with inflammation and we can't find them, HIV positive people. It's really hard. It's not every single person walking around with HIV is in this inflammatory storm, and we have to screen a lot of folks to get into a lot of our studies. So I think that's something people should appreciate.
Because that's now in Grace's study for Saturn, there was a requirement, right, for a higher CRP or high T cells.
Right.
So, and that she probably had to screen quite a few patients
in order to
reach
get
that.
that.
Yeah.
I think that's true.
I think that also the message is that we need to test more classic interventions that have been, you saw some effect in the general population, and to that there are 3 studies that are going to open in the AIDS clinical trial group, and for people that are interested in this issue, I think it's time to do systematic evaluations of interventions. There is a study that is going to look at aspirin, low dose, high dose. There is a study that's going to look at statins, maybe a huge study in patients with HIV that hopefully will be funded and hopefully will be opening soon. And you have a study looking at low dose methotrexate, which is an anti-inflammatory that has been used in rheumatoid arthritis, weekly doses of methotrexate, and looking also if that as a pure anti-inflammatory can have an effect. And I think we need to learn more. And there is an opportunity for patients that want to be involved to participate in these trials and to get the right answer.
So
the trial is limited duration, and that might be
Right.
an intervention that will last for the next 10, 15
Right.
years. So we need to learn from these studies what to do for
Well,
the
the
next
statin study will hopefully go on for a really long time
Yeah,
and collect
yeah, yeah.
endpoints, so it's going to be a really massive, important effort. I'll just to play a little devil's advocate, because I think these are really important studies, and they're good. The methotrexate study clearly is a probe for can we really change things on this one particular level. I was really struck by how people were paying attention to some of these other factors, including depression, and how depression has been associated with outcomes that are not good, including cardiovascular disease. And it kind of makes some intuitive sense that people who are depressed are people who live with PTSD or are stressed. Cortisol levels are high. There's other things. I'm sure there's inflammatory markers that are high too.
There is a connection between the brain and the inflammation.
Absolutely.
And I'm biased here because we presented that on aprepitang, which is an NK1R receptor antagonist, which that drug is approved as an antiemetic, but was studied by Merck as an antidepressant. And because it was no better than with the current available antidepressant, the program was killed. But blocking, which is involved in nociception and it has receptors in the brain, it was associated with decreases in soluble CD163 in our study, decreased expression of PD-1, and decreased substance P levels that have been associated with progression of HIV disease. So there is definitely a connection between the brain and inflammation processes that we have not figured out yet, and there is a connection. Curiously, in that study, blocking that receptor increases cholesterol, but decreases your markers of inflammation. It's a little bit weird, and you worry about small sample sizes, but there is a connection, and it's important, as you said.
But I do think in the VA studies where they've looked at this mostly, I think that connection between being depressed without HIV and having coronary artery disease or coronary events is really important. And with our population, where we have HIV plus depression being very prevalent, I think that is another confounder and also maybe another lever that can be pushed, because depression is treatable if it's recognized and taken seriously.
Yeah, you mentioned PTSD, and they've coined a new term called AIDS survivor syndrome for the long-term survivors who've been through the whole scope of the epidemic and have suffered so much, and over time they've become less and less resilient and more susceptible to depression. So I think it's a huge issue, especially as our population ages with this.
Yeah, I think I have seen that PTSD in people that lived through the first decade of the epidemic, and as you said, they get tired and depressed. There were some prominent activists in New York that basically...
Yes, right. Spencer Cox.
Yeah, so,
just gave up.
And there was an article in the New York Times talking about
Well, I would say I could completely identify with that and understand that. The other point, we are in a really exciting phase of this epidemic. I think we're beginning to see the very start of the end, and I don't think that's just, being hyperbole. I think there are some really great glimmers of hope. And so we talk to a lot of our patients about being around for the cure, being around for the next best thing of the cure, whatever it is, but that there's a lot to go on and live for and see. The story's not over. We've got a lot to go.
There's certainly a lot to be optimistic about.
Yeah.
The drug combinations that are being developed now for first-line treatment are much better tolerated than the drugs we had even just 10 years ago. Right. And I think we're going to see that is the new standard. Yeah. As I heard Graham Boyle say a couple of weeks ago, tolerability is the new potency.
That's right.
It doesn't matter whether or not your drug regimen is potent, because all drug regimens are going to be potent. but the best regimens are going to have essentially no drug-related side effects.
That's right.
And we're already starting to see combinations of drugs very close to that.
And
So-
that's what's exciting is that, and I completely agree with what Graham said. And it's not even tolerability as far as grade 3, 4, so moderate to severe adverse events. We're talking the battles between mild to moderate adverse events. So if this drug has a little bit more nausea than another drug, that's a problem. Because we don't want people to have nausea. Even grade 1 nausea is not anything anyone would want, so mild nausea. I think that's exactly right. That's differentiating these as well as convenience.
We also heard some progress at this meeting about moves to develop injectable antiretroviral regimens, and for people who have developed pill fatigue and survivor syndrome, one of the things that pushes that is having to get up every day and take pills to keep this virus under control. Now we have the opportunity finally to come to the doctor's office and get an injection, maybe once a month, maybe once every 3 months, eventually maybe less frequently than that, to keep the virus suppressed and give people the chance to get away from pills if that's something they want to do.
Yeah,
That's
it's a
great.
daily reminder.
And that's the next horizon.
Terrific. Well, thank you all. This has been really exciting, and to end on an optimistic note, and continue doing the great work and research that you do to continue to improve the lives of people living with HIV. Thank you.
Thank you,
Thank
Jeff.
you.
Thank you.